Assalamu alaikum, everyone. Welcome back. My name is Shafiq Qadri. I am one of your conference coordinators this year, and it's my pleasure to welcome you to our third session of the day, which is entitled Understanding and Addressing Suicide in Diverse Muslim Communities. We have a few bits of housekeeping to get in the way before the session begins. A reminder to please complete the feedback form that will be sent to you after the conference is over. This is how you get your accreditation hours and also helps us to improve the conference in the future, so please fill it out. In addition, we encourage you to post about our conference on social media, and if you do so, we'd love to have you use our hashtag, which is hashtag CMMHC2021. A note about the content of this session in particular. We understand that it might be triggering for some individuals, and we would like to be mindful of that. If anyone would like to step away and return to the conference at a later date when you feel more comfortable, you're more than encouraged to do so. In addition, I would like to flag a resource, the Canadian Suicide Prevention Centre, whom you can contact at their toll-free number, which is 1-833-456-4566. So again, this session is entitled Understanding and Addressing Suicide in Diverse Muslim Communities, and we are joined by two excellent presenters, Dr. Zainab Furqan and Sheikh Hosam Helal, and I'll just introduce them briefly. So Dr. Zainab Furqan is a clinician researcher at the University Health Network. She works in the outpatient setting, providing psychiatric services to the community mental health clinic and the urgent care clinic. Her research is focused on suicide prevention and understanding the lived experiences of people who use mental health services, as well as the cultural dimensions of psychiatry. She has an interest in understanding and addressing the unique psychiatric needs of Muslim populations, which is of course very relevant to the session that she's going to have today. Sheikh Hosam Helal is a member of the Muslim Mental Health and Islamic Psychology Lab at Stanford University, run by Dr. Awad, who is a presenter in the first session. He has authored a chapter on suicide in the upcoming APA book titled Muslim Mental Health. He serves as an Imam and a youth education manager at ISNA Canada, as well as an associate Muslim chaplain at Brock University. After completing his Islamic studies at Al-Azhar University, he is pursuing graduate studies at the University of Toronto in Quranic exegesis and evolutionary biology. He is also a guest contributor for the Yaqeen Institute for Islamic Research. So with that, I would like to invite Dr. Furqan and Sheikh Helal to take it away.
All right. Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah, alhamdulillah, wa salatu wa salamu ala rasulillahi wa ala alihi wa sahbihi wa man wala. Jazakumullah khairan for the opportunity to speak, and I'm humbled to be with you, and I ask Allah subhanahu wa ta'ala to make this a beneficial conversation for all of us, ya Rabb, ameen, ameen, ameen. So the topic of suicide is a vast one, and it's a very sensitive one for the Muslim community. And I would like to begin by looking at one verse in the Quran where Allah subhanahu wa ta'ala says, وَلَا تَقْتُلُوا أَنفُسَكُمْ إِنَّ اللَّهَ كَانَ بِكُمْ رَحِيمًا. And do not kill yourselves, for Allah subhanahu wa ta'ala is the most merciful towards you, is the most merciful towards you. Now, that's a verse that is within the Quran, but the way that that verse is carried within our tradition, it's actually very interesting. If you look at the books of exegesis and tafsir and hermeneutics, you'll find very few scholars actually interpreting that verse to refer to suicide. That most of them will say that the verse actually should be understood as a prohibition against murder, against killing others. And the reason why they would actually provide the justification that the phenomenon of basically, suicide wasn't as rampant or wasn't as common in the early Muslim community, so that the mufassirun, those who are writing commentaries on the verses, didn't actually think it was necessary to mention suicide, that they understood the verse to be referring to basically the murder of others. But if you look at the books of fiqh, the books of jurisprudence, that's where we have discussions on suicide, and discussions on specifically contagion, and discussions on the way that Muslim communities should react to it. Now, what's interesting here is the books of jurisprudence actually go back to a story involving the Prophet Muhammad sallallahu alaihi wasallam. And a man comes to the Prophet Muhammad sallallahu alaihi wasallam, and he tells him, Ya Rasulullah, one of my family members basically died of suicide. And the Prophet Muhammad sallallahu alaihi wasallam, asked for more information, what happened, and more information is provided. And at that time, the Prophet Muhammad sallallahu alaihi wasallam asks the companions to pray the janazah, to pray the funeral, but he himself opts out of praying the funeral prayer. Now, in discussing this, the books of jurisprudence or fiqh, they have to basically understand like what happened there. Why did the Prophet Muhammad ﷺ refuse to pray the janazah of someone who died of suicide? And then they relate this to suicide contagion. They say that the Prophet Muhammad ﷺ had to basically deter others from the act, and he chose not to lead the prayer himself. But by giving someone else from the companions and by asking the companions to pray, he affirmed the belonging of the individual who died of suicide. So here he's trying to balance between two things. Number one, limit the contagion aspect of things. So basically that this is not an acceptable way to leave this world as a Muslim. And the verses and the hadith, especially the hadith, are many. And you'll see the Prophet Muhammad ﷺ, for example, saying that a person who dies of suicide in this specific way will be tortured or will be punished in front of Allah subhanahu wa ta'ala in the same way. Now, at the same time, that does not mean, and here's the most important thing, that does not mean that the person who dies of suicide is actually condemned to hell or condemned to a punishment. Because at the same time, a man came to the Prophet ﷺ, and this was the family of At-Tufail, who actually migrated from Mecca to Medina. And upon migration, he had a really, really difficult time coping with the humma, the fever of Medina. And as a result, he died of suicide. So the Prophet Muhammad ﷺ, when the family came crying, Ya Rasulullah, we don't know what's going to happen with our son. I don't know what's happening. And they were very, very affected. So the Prophet Muhammad ﷺ, he responded and he says that I actually had a dream, and the prophetic dreams are considered to be a form of revelation, that this individual, the son of yours, is actually in Jannah, is actually in heaven. And Allah forgave them and Allah replaced that limb for them. So there are three, when you look at these prophetic traditions and stories, you will see a few things. You will see, number one, that the Prophet Muhammad sallallahu alaihi wasallam, he shut the door for suicide. He shut the door for suicide through very, very clear prohibitions. Whoever dies of suicide will be tortured in the same way on the Day of Judgment. But at the same time, he said that some people who die of suicide, Allah subhanahu wa ta'ala may actually forgive them, and Allah subhanahu wa ta'ala may give them Jannat al-Firdaus. So we cannot make an individual judgment. We cannot judge this person is going to Jannah or this person going to Jahannam, because that's not up to us. But we have a categorical prohibition in the Quran, which really helps us as Muslims and us as clinicians. When we're talking about, subhanAllah, suicide, we should do the best that we can to understand where the person is at, but also limit the contagion aspect and limit the contribution aspect. Like we don't want to be the reason that somebody considers it, but at the same time, when it does happen, we want to give people hope and mercy and chances at redemption. And the best example of this is actually highlighted with Ibn Abbas. A man comes to Ibn Abbas and he says to Ibn Abbas, I am pretty much in confusion. I don't know what to do. What does Islam say about murder? And Ibn Abbas started talking about murder as though it's one of the biggest and the worst things that he can do. It's a major sin. Don't do it. Don't consider it. And then a while later, another person comes and asks Ibn Abbas the same question, like, what does Islam say about murder? And then Ibn Abbas says to this individual, do you have a mother? Is she alive? Go and take care of your mother. Allah can forgive anything. So the people that were around Ibn Abbas, they told him, why are you answering the same question in two different ways? Why are you answering this person by saying it's the worst thing possible? And then to the other person, you're saying that Allah can forgive anything. And Ibn Abbas said the first person that came to ask, they had not committed the act. They were thinking about it. So for someone who did not commit the act and they're thinking about it, we do the best that we can to shut the door for the act, to shut the door for sin. But once sin has been committed, we do the best that we can to give people hope and to fill people with the notion that Allah subhanahu wa ta'ala is the most merciful and He's the most forgiving, and that there's nothing that is greater than Allah subhanahu wa ta'ala's capacity to forgive. Now, what's interesting here is if you look at the schools of jurisprudence, when they're talking about suicide, the Hanbali specifically, they mentioned that the Imam of the community should not lead the prayer of someone who died of suicide, without mentioning that to the community. Like, it should not become public knowledge, it should be kept private. But the Imam of the community should not pray that janazah. And the understanding there is that it doesn't become something that is normative within the Muslim community. That yes, the individual belongs to the Muslim community. Yes, everybody should pray the janazah. Somebody else should be assigned to pray the janazah. But the Imam, the main Imam, should not pray the janazah. So it doesn't become, in the eyes of people, in the minds of people, an acceptable reality. And again, they say that this is to shut the door for suicide contagion, because in Islam, we have a hadith of the Nabi Sallallahu Alaihi Wasallam in which he says that whoever introduces a concept and basically other people mimic that concept or mimic the act, that person may actually end up carrying that burden of their action and the action of others. And we've seen, for example, movies that celebrate suicide and shows that celebrate suicide, and even communities that kind of, don't take a stance that is, firm. When the deterrence doesn't happen, it might lead to a contagion impact. And we've seen that, if you look at the Muslim community, even within the GTA and others, we've seen that both anecdotally and also within research, that it does have an impact on others. Now, I'm going to leave some of the more, like the scientific approach. I'm going to leave that to my co-panelist. May Allah bless her. But for now, I want to focus more on, again, the Islamic aspect of suicide. And we as Muslims, if you look at like our paper that we wrote together with Brother Bilal for the Muslim Mental Health Lab and Islamic Psychology Lab at Stanford University, we looked at basically the way that Muslims should view suicide and the way that we should think about suicide, especially from an Islamic ethics point of view. So we understand that trials and the prohibition of suicide should be understood as, within three things. And we call this the prohibition triad. Number one, that trials are a test from Allah subhanahu wa ta'ala. And we know this as Muslims, that difficult things can happen to us to prepare us for that which is better, to purify us, to get us to be closer to Allah subhanahu wa ta'ala. So that there's actually a benefit. There are many benefits to basically Allah subhanahu wa ta'ala allowing us to be subject to tests and trials. And Allah says in the Quran, sometimes Allah subhanahu wa ta'ala might give you what seems to be difficult for you, only for it to basically be better for you in the long term. In addition to that, that you have basically rights of the body and rights of the community on the individual. That your body has rights upon you, and your community has rights upon you. So for example, one of the rights of the body is that you preserve your body. And the ending of the life, or ending of the body, or limiting the body, or actually hurting the body, for example, depriving the body of food or energy, would be considered to be a sin in Islam. So obviously ending one's life would also be considered to be a sin in Islam. And if you also look at the third reason, we have from an Islamic point of view, a very important value attached to the human life. One of the maqasid, one of the foundations and the purposes of the Sharia is to preserve the human life. And also one of the most important and the most rewarding things is to preserve the human life. The Quran makes it clear, whoever saves one life, that is equivalent to saving all of humanity. And in addition to that, we have, for example, the Prophet Muhammad ﷺ saying that the life of one Muslim and the blood of one Muslim is more sacred to Allah subhanahu wa ta'ala than the sanctity or the sacredness of the Kaaba, the Kaaba. So imagine if the Kaaba were to be destroyed, most of us would react in a very, upset or disgusted manner. But when one life is compromised from an Islamic point of view, the reaction should actually be much, much more intense. And that's what the Islamic tradition reminds us of. Now, you'll see, of course, there are related topics also from a jurisprudential point of view. You'll see the conversation on euthanasia or assisted dying, and the conversation on basically suicide as an attack or a defensive mechanism, including suicide bombings. And if you look at our tradition, it's actually very interesting because during Imam al-Ghazali's time and during the Crusaders, what was happening is the Crusaders were using Muslims as human shields. They were using Muslims to basically line up their attack as they're attacking other Muslims. So the question came, are we allowed to basically attack back in order to save these cities and to save these towns at large, and that might actually risk the lives of one or two or three Muslims that are used as human shields by the Crusaders. And some scholars basically said, well, this is a very tough situation to be in. If you don't, you might lose big cities and big towns. And if you do, you're actually going to be compromising the lives of fellow Muslims. So you have Imam al-Ghazali coming in, and he actually makes a very strong stance that it is not to be done under any circumstance, that it's actually considered to be a haram and considered to be a big harm within the Muslim community and in the sight of Allah subhanahu wa ta'ala. And he encourages that the Muslims actually find ways around suicide, like around the use of human shield, around the death of fellow Muslims in order to preserve the lives of other Muslims as well. And his fatwa becomes, one of the main fatwas within the tradition. But then you have other fatwas from scholars who basically say that yes, it could be used, and they say that the lives of many are going to basically become to save the lives of many is a necessary thing. And then at that, there might be justification here available to basically yes, use or defend against the human shield of Muslims, and actually end up killing Muslims in the process. So this becomes one of the main foundations that are used by people who belong to ISIS and people who belong to terrorist organizations, that they use these fatwas out of context to say, look, the Muslim tradition says you can do this and you can do that. But remember that these are very minor fatwas, and they're contextualized within very specific situations, and we have to be cautious not to take them out of these situations. And I'll leave the euthanasia discussion to, again, my fellow colleague. Now, in terms of suicide contagion specifically, we've seen that reports of suicide, especially in the news, they're associated with spikes in suicide rates. And this actually has been studied, for example, in the Middle East and in Muslim countries, where after the report and the janazah, you see large numbers coming out to attend the janazah of someone who died of suicide. And right after, in the same week or in the same 2 weeks, you see a spike, sometimes up to 15% increase or 20% increase in suicide attempts and in suicide deaths at that time. And so if we have a duty as a community to protect against copycat suicides, as I mentioned earlier. And the tradition is very clear about this in two ways. In the reception side, that the person who is thinking about suicide has to has their own agency, and they're going to be required to employ their own agency in the process. And I'll explain what that means in a second. And we also as a community have to be careful in terms of maintaining a community narrative that is constructive and that is also supportive of moral formation and ethical formation in the larger community. So for example, the Prophet Muhammad ﷺ, he says, لا تكن إن أحسن الناس أحسنت وإن وسأت. Don't be one of the many. Don't just go with the flow. Don't just follow. If people do good, you do good as well. And if people don't do so good, you do the same. And then the companions added, rather be a critical thinker. When people do good, you do good. And when people do bad, you offer a solution, that you become a reason for people to question and to be critical of, their positionality and where they stand. And so what's interesting here is that this is usually used by the jurisprudence scholars to say that, yes, you have a duty to basically preventing copycat suicides as a community, but the individual also has to understand that I'm responsible for my actions. And also the person that is committing or thinking of suicide has to understand the implications, the cascade effect of their decision. And that doesn't actually, here's the thing, that doesn't mean that becomes an added stress. Like I have to worry about myself, because someone who's already thinking about suicide is already going through a lot. So to add on to them the burden of having to think about what's my community how is my community going to react, and this, it's actually supposed to be a representation of your worth and your value in the Muslim community, that you do belong, that you do matter, that your actions do have a weight. And not only do they impact you and your family, but they impact the community at large. And that's the way that it should be framed. It should be framed in a narrative of self-worth, that Allah subhanahu wa ta'ala considers you to be important. And that's why suicide it's considered to be haram, and it's considered to be sinful. And that's why you have to think about the implications. But also on the ground, we as a community have to be respectful, and we have to have rahmah and mercy in the way that we deal with the families of people, in the way that we discuss suicide. So, for example, in one of the training sessions in the manuals that the Muslim Mental Health Lab has released, there was a discussion on the words and the way that we employ words. So, for example, we're not going to say someone committed suicide. We actually say someone who died of suicide, because committed suicide makes it again, blames that person, puts the onus of blame on the individual, when in reality, that in many cases, individuals who are going through these difficult situations, they might actually be victims of their circumstances, and victims of, whether it's psychosis or depression or anything else that leads to that act. And Muslims actually of the past mention that somebody who is in that state where their agency is compromised because of psychosis or because of anything else related to mental health, that Allah subhanahu wa ta'ala is the most forgiving and the most merciful. So we shut the doors beforehand to the act. We deter as much as possible as a community, and we're careful how we portray an incident after its occurrence to shut the door for copycat and contagion. But in between, in the way that we deal with individuals, we're as compassionate, as merciful as possible, as understanding as possible, as constructive as possible. And to the family, we are as respectful as possible as well. And of course, one great example of this is the way that the scholars relate this to the hudud for zina, for example. And I'll finish with this. We know, for example, that the punishment for committing infidelity inside marriage and outside marriage is harsh from an Islamic point of view. But the story of Ma'iz is a very interesting one. So this companion comes to the Prophet ﷺ in the middle of a lecture, and he interrupts the lecture and he says, Ya Rasulullah, O Messenger of God, I want to be punished right now. I committed zina. I committed infidelity. So the Prophet Muhammad ﷺ turns away from him. He ignores him. He gives him a chance to rethink. And then, of course, Ma'iz comes again and he says, Ya Rasulullah, did you not hear me? I want to be punished right now. I want to be purified. And the Prophet Muhammad ﷺ ignores him twice, 3 times, 4 times, and one narration 6 times, before finally he turns his attention to him and he says, what's going on? Like, I'm intentionally giving you a chance to revoke your statement. You don't need to incriminate yourself. Allah is the most forgiving, the most merciful. And then he says, no, I really want this to be done. He says, okay, go back home. And the Prophet Muhammad ﷺ actually sends companions to check, like, is he okay? What's going on in the house? Is his mental well-being, or is he in a state where he can make that decision? And the community, or the Prophet Muhammad ﷺ sends 2 members to go and ask his family if he's okay. And then they go and they check and they find out that he's completely fine, and he's insisting on basically going through with this. Now, the most interesting part of this is actually when he does say, okay, if this is what you want, this is what you're going to get, and he explains to him what that punishment is, and the companion seems to be very comfortable with that, and he wants to go ahead with that. What's interesting and authentic is the narration is authentic, is while they're implementing the had, while they're implementing the punishment, what happens is the Prophet Muhammad wasn't there, but he did assign members of the community to carry out the punishment. What happens is basically the tools that they were using to carry the punishment kind of fell, and then at that time the companion realized, oh man, this is serious, and he actually tried to run. He actually tried to run away from the punishment, and as he was trying to run away from the punishment, they caught him, they bound him, and then they carried the punishment. When this came back to the Prophet ﷺ, he says, why did you do that? He should have accepted his fleeing from the punishment as his quest for redemption, and perhaps Allah may have accepted his repentance. Perhaps Allah may have accepted his repentance. Now, this becomes a very important narration in terms of, and it's not one that's talked about often, but in terms of giving people second chances, that even the kaba'ir, even the major sins, when we talk about them, they're still kaba'ir. Categorically, they are major sins. And we shouldn't in our conversation undermine that, because the rules of Allah subhanahu wa ta'ala categorically are not for us to interpret or redefine. Those are rules that are set by Allah categorically. So whatever is considered to be a major sin, we consider that to be a major sin, and we talk about it as a major sin because there's a deterrence that comes with that. But in the way that we implement the hudud specifically, and in individual cases, we do take into consideration the person's well-being, the person's repentance, the person's incidence ratios and how many times this has happened in the past. And we do as much as we can to give each and every individual a chance at redemption and a chance to connect with Allah subhanahu wa ta'ala, to seek that repentance. And the same thing applies to suicide, that it is considered to be a major sin in the construction of the jurisprudential scholars, but at the same time, it is one that Allah subhanahu wa ta'ala can forgive, and it's one as a community that we have to deter against, but at the same time, make individual accommodations as needed for the individuals themselves affected and for the families of the individuals affected. And that accommodation means we speak about in a sensitive way, in a way that actually describes and affirms the belonging of the individuals to the community, and in a way that also gives people hope and prevents others from considering that to be an acceptable option. Jazakumullah khairan. May Allah bless you. Hope this was beneficial, and we'll pass it on. Barakallah feekum.
Assalamu alaikum, everyone. Thank you so much, Sheikh Hosam, for providing that context. I will get started on my slides. Give me a moment to get the setup. Okay, so as was mentioned previously, my name is Zainab Furqan. I work as a psychiatrist at UHN, and I have a research interest in catering and refining mental health treatment and approaches to Muslim populations to meet their needs. It's such a blessing to be here with all of you today. Assalamu alaikum. And I just want to take a moment to thank everyone who's been involved in putting together this conference. I know many of them personally. I've been involved with the organization of this in the past. I can tell you it's so much work, and many of the people who are doing it are working as full-time physicians and clinicians during the day and doing this during weeknights and weekends. So if you can, please send them a note of gratitude. And if you do identify as Muslim, please make some dua for them. I'm sure they would appreciate it. I have no disclosures to report, and this has been mentioned a few times already, but this is a sensitive topic. Suicide can affect us all. It may raise, the discussion of this topic might raise some emotions for you, so please make sure you're taking care of yourself, and there are some resources here if you need to access them. My objective specifically is to provide you about a little bit of epidemiology about suicide in general, and then specifically within the context of Muslim communities, talk about the importance of incorporating religious considerations when you think about safety planning and dealing with clients who are going through suicidal thoughts or behaviors. And then this has already been covered a bit by Sheikh Hosam, so maybe I'll keep this briefer, but strategies for responding to suicide deaths on a communal level. And the way I'll do this, just to give you a bit of a framework, I'll start with a case presentation. It's loosely based on someone that I've seen, several people actually, to make sure that I'm preserving anonymity. We'll talk about the epidemiology, the religious considerations, and then some really practical approaches that you can implement in your clinical settings. So I always find it very helpful to think about actual people and cases. So I'll tell you about Sarah, a 17-year-old young woman who does identify as Muslim. She's living with her parents and 2 siblings. She's been having a really tough year, and for the past few months has been having so much anxiety, feeling it all day, staying awake with it, having panic attacks where she's breathing really heavily. When she starts talking to clinicians about it, she discloses that there is definitely some bullying going on around her Muslim identity. And she also discloses that she has been self-harming by cutting herself on the arms. And then sometimes also has the urge to what she calls just end it, that her suffering is so great, she can't tolerate it anymore. She has these urges. So I will come back to this case at the end after telling you a bit more, and we'll talk about how we can approach this. So giving you some background context, as Sheikh Hosam had mentioned, suicide is one of the leading causes of premature death in Canada. When we think specifically about young people who 10 to 25, it's the second most common cause of death. And so in Canada, 4,000 people die by suicide every year. And what really is striking to me is that for every person who dies by suicide, we approximate that about 25 to 30 people are attempting suicide, which to me, it really indicates the level of distress and suffering that people are feeling to be getting to that point where they're attempting suicide. It's a very complex phenomenon, and I'm really glad that Sheikh Hosam mentioned this. It has biological, psychological, social considerations. We do not have any single simple, clear explanation for suicide. What we know is that it's multifactorial and influenced by multiple different factors. One of the factors that we know is very important is mental illness. This is why this is so important in psychiatry. When they've looked at studies evaluating deaths by suicide, we found that 90% of people who die by suicide were known to have a mental illness. And when they've tried to replicate these studies in Muslim majority countries, they found similar patterns. So for example, in Karachi, when they did psychological autopsies, which is looking through the data of people who die by suicide, 96% of them were associated with mental illness as well. So while again, I definitely approaches, we do know that mental illness is a very strong factor when we think about suicide, and it cannot be ignored. It's very important to address. When we think about risk factors for suicide, one of the most significant is having a history of what we call deliberate self-harm or suicide attempts. So having had that behavior in the past puts you at risk of future incidents. Men in general are at much greater risk of completing suicide, whereas women, the attempts can be high, but when we look at completed suicides, men are at higher risk. There's some variations in geography for that, but especially in Canada, that's a fairly clear pattern. Like I said, mental illness, quite prevalent. Age is an important factor. So between the ages of 45 and 65, for particular in men, that's a very high risk period. And then after the age of 80, we see another rise. Isolation is big, and substance use, because it decreases inhibition, that natural inclination or inhibition to prevent harm to yourself. Substance use can diminish that and place people at greater risk. These are the statistics from Canada. It's a bit of an older table, I apologize, but the pattern holds. If you see for men, the highest rates really are in that period of 40 to 60. And then similarly in females as well, that period is of higher risk. Protective factors, these are very important to talk about. So one really important protective factor is engagement with effective healthcare. Social connections, so being married, being in a partnership, communal involvement and engagement. They've looked at cognitive factors. So for example, problem-solving skills and abilities can be important. And then this idea of religious and spiritual beliefs and practices, which I'll elaborate on a bit more. So this idea of religion and suicide, what traditionally within the field of suicidology we've thought about is that religiousness and religious attendance is associated with a lower risk of suicide across the data, which is good news. So when they looked at a meta-analysis looking at all the studies that have been done around this, so 68 studies, when they did a review article, they found that there were decreased rates of suicide and increased negative attitudes towards suicide in those people who identified as religious. The problem, however, becomes that the idea of religious affiliation is very broad and very contextual. So we have to think about specific factors, right? When we think about ways that potentially religion might be protective, traditionally the first thing that kind of comes to mind is religious doctrines that prohibit suicide, right? So for example, across the Abrahamic faiths, suicide being prohibited, we think about that as the major reason why there might be lower suicide rates. But it's more complex than that. There are other ways that religion might be protective. So for example, when people are having suicidal thoughts and ideas, one of the key associated emotions that they will report is hopelessness, lack of purpose. And so religion might be providing this comfort and meaning and purpose that helps to ward off some suicidal thoughts as well. And also being involved with religious communities may provide enhanced social and communal supports that can also offer protection. So the slide, the take-home message for that I'd like you to walk away with is that in addition to prohibitions, we have to be thinking about these other ways that religion and spirituality might be serving to protect people against suicide. One really interesting phenomenon that has been found is that in certain Muslim majority countries like Turkey, they found that during the month of Ramadan, suicide rates and suicidal behaviors or self-harming behaviors decreased compared to the rest of the years, and they replicated this across years. So again, pointing to there are different things. So it doesn't mean that in Ramadan people are less aware about the prohibition against suicide, but they're more engaged in their spiritual practices. They're more connected to the community, and so we think that's what might help further decrease suicide rates during those months. Now, when they compiled WHO data, this again is a while ago, so they did find that compared to other countries of other religious dominations, Muslim countries did have significantly lower suicide rates, which is great news. Again, I'm in general, being in this field, as many of you know, we have to be careful of simplistic narratives. So what are the factors that are going into this? So some of my patients who have come from Muslim majority countries have told me that when they had attempts in those countries, because of the stigma associated with suicide and because of in some cases, their legal punishments, their attempt wasn't classified or reported as a suicide attempt. So we do have to be a little cautious about how to interpret this data because there can be several factors that go into how rates are being reported and portrayed. Now, the North American context becomes really important. So Dr. Awad, like you heard from this morning, is leading the charge. We're so blessed to have her as part of this community and as part of the psychiatric community and the suicidology community. But she she and her team published this paper in JAMA, which is a major medical journal, which looked at suicide attempts among Muslims and comparing that to other religious populations. And I apologize for the small size of the font here, but what you'll notice is that the Muslim respondents in the survey actually had the highest rates of previous suicide attempts. In some cases, they were twice as likely. The odds ratio was 2.18 compared to other religious populations or non-religious populations in terms of having a previous suicide attempt. So this is really eye-opening work, and I think really important for us to recognize as a community, because the Muslim community in a North American context or European context where there are religious minorities, they face many other additional stressors because of their religious identity, the issues with identity, issues with belonging, socioeconomic factors, discrimination, racism. All of these are also contributing to a person's risk of suicide. So it's very important that we understand for specific communities. So for example, that the data that we get from Muslim majority countries cannot necessarily be extrapolated to Muslim communities in Canada and North America. And we really need to be creating research hubs and data-based in our context. So I'll just briefly mention too that my team and I here in Toronto and Canada, we are also looking at rates of suicidal behavior, suicidal thoughts among young Muslims in Canada, and really trying to build this data for specific contexts. Those will be, they're in the works, and inshallah, we'll be able to present them to you soon. I won't go into this in detail at all. I identify my limits as not being a religious scholar. I'm very appreciative for the religious scholars who are doing amazing work in trying to enhance understandings of suicide that are really grounded in the Islamic tradition. One note that I will mention is that there are very complex issues, like Sheikh Hosam was mentioning, around the idea of accountability and being sound of mind when a person dies by suicide. And so followers, when it comes on an individual level, we are asked to leave judgment to God. And so really none of us has the ability, whether we're clinicians or imams, we do not have the ability to see into the hearts of people. Only God has the ability to do that. And we're asked to leave that particular judgment to God. That does not detract or deny the reality that there are certain religious aspects and prohibitions when it comes to this topic. Now, as we know, there's a lot of stigma around suicide. So in the people that I've talked to, in the young people I've interviewed who have had histories of suicidal behaviors, having these thoughts and attempts in the past causes religious guilt and shame for these people, which then exacerbates their suffering, which makes their suffering worse. And it also prevents people from reaching out to help. There is this immense shame in thinking, well, if everyone else thinks that it's sinful, why would I bring this up? Why would I get help around this? I'll probably receive more judgment around this. So it can really detract from people being able to ask for help. Next, as we were talking about earlier, families of people who have been going through suicidal behaviors or attempts in the past, they may experience exclusion or ostracization, and so that might prevent families from seeking help and support around this as well. And then, thankfully, I'm seeing less of this encountered in practice, but there is still this belief, I think, that talking about suicide or asking about suicide will cause suicidal thinking or attempts, and that's simply not true. As we'll talk about a little bit, contagion is a different matter entirely, but asking about suicide and openly exploring it will not in and of itself create suicidal thinking. It will help alleviate distress. Another really important point that I want to mention is that thoughts do not equal actions. I love this verse from the Quran in Surah Al-Maryam, where the verse states, the pains of childbirth drove her to the trunk of a palm tree. She said, oh, I wish I had died before this and was in oblivion forgotten. But he called her from below her, do not grieve, your Lord has provided beneath you a stream. It's such a beautiful depiction of this idea that many of us go through pain and suffering that can sometimes lead our minds to wander in this direction, which in and of itself, that is normal and part of the human condition. However, acting on it is a different matter. So many people have these thoughts. It does not mean that they will act on them. At the same time, thoughts, suicidal thinking can be an indication that help is needed and that we do need, that person needs to reach out and seek out support. So what does all of that, putting that into context, what does that mean for us as clinicians? Why is asking about religion important when it comes to suicide prevention? Well, like we talked about, first of all, by not asking about it, you may be missing an important protective factor against suicide. Many people that you talk to in the Muslim population will say when they did have passive thoughts of suicide, when I say passive thoughts of suicide, I mean thoughts where they didn't want to act on them, but they had this idea that death might be better than suffering, that what held them back are their religious beliefs and practices. So you really need to be, if this is at play, then without exploring it, we might be missing out on it. Also, in my work with Muslim communities, religion is such an important part for so many people. Again, we cannot apply this as a blanket statement. Each person is unique, but for many of the people I've worked with, younger and older, their religious identity, even though it might be in conflict, even though they might be in a state of exploration, it's such an important part of who they see, how they see themselves as a whole person. And when that's not touched at all, when they're in a mental health setting, people feel like this really big part of them is being ignored. And so I think that's why it becomes really important for clinicians to bring this up. And also, we know that it can affect treatment, what we call treatment adherence. So when clinicians are making recommendations for treatment, having this idea of cultural safety, cultural competency can enhance the likelihood that the people who are coming to you will actually adhere and take you up on your recommendations. So when it comes to actually talking about suicide in a clinical setting, the first general principle starting off is to create a very safe and comfortable environment. You as a clinician are not there to pass judgment or to provide your own moral stances. You really are there to create a space that's safe for that person to disclose their emotional and psychological suffering. And so asking openly about suicidal thoughts can become much easier if that environment has already been created, where that person feels that even though as a clinician, you may not agree with what you're saying, that you're not going to be there passing judgment on them and making things worse for them. So I really try to first create a therapeutic alliance with the patient, try to understand them as a whole person, and with my verbal and nonverbal cues, try to indicate to the person that they're safe here, and then get to the part about exploring suicidal thoughts. Now, when you do ask about suicide, it's important to do it in a straightforward manner. The way that I do it will be, have you ever had thoughts about ending your life? Rather than beating around the bush and trying to say it in a very tentative way, asking about it as a matter of fact, and then differentiating between is, okay, so you've had thoughts, has that translated into you planning to act on these thoughts at all? Preparatory behaviors are really important and often not mentioned until we explicitly ask about them. So for example, when I'm working in my practice or in emergency settings, I always ask, have you done anything like research ways of completing suicide, trying to read up on it, gathered any materials? So for example, a person, it's only after like creating that therapeutic relationship, discussing this openly, then let me know, yes, they'd actually purchased a rope, it's in the closet, which then set off some alarm bells for me. So it's really important to just not stop at the thoughts piece and to actually go into whether or not there's intent or planning behind it as well. And then I find that we often miss this. We're so focused on the risk factors that sometimes we miss asking about protective factors. So really asking, like, you've stayed quite resilient. What helps you stay here with us? What gets you to seek help? What do you look forward to? In kind of helping the person articulate for themselves sometimes and for you, what are the factors factors that are really keeping them grounded and countering some of the suicidal thoughts that they might be having. What I also try to normalize for people is that both can exist. There can be that part of you that is drawn towards this, but it's really important to highlight for the person that there is this part of them that wants to be here. That's why they're here with you seeking help. And while we cannot assume the reasons why they're doing that, it's always helpful if the person can articulate to themselves and to you what keeps them going, what makes them tick, what is giving them a little bit of hope that they're here talking to you and seeking out help. I'm just going to comment that I don't have the chat open right in front of me, but I will make sure that towards the end we have some time for questions, so bear with me. So people ask me, and this came up in the last the lecture as well, is how, like practically speaking, when we work often in psychological and medical settings, unfortunately, our understanding, the biopsychosocial model, can be so divorced from spirituality and religion that people can be very uncomfortable talking about this. And early in my training, I was too. Would I be seen as someone who is not as professional, who is not adhering to evidence-based or scientific ways of evaluating psychiatric concerns? The truth is that our understanding of mental health is evolving significantly, and there is a push from many of us to incorporate religious and spiritual aspects of mental health into our assessments and treatment plans. And so these questions that I'm showing you are actually drawn from the DSM-5, which is the major manual that we use. And so, for example, framing it as, do you identify any particular spiritual, religious, or moral tradition? Can you tell me more about that? Keeps it really broad and open and allows the person to give you information about how they implement spirituality or religion in their life. And then keeping it really broadly. So I will ask people, what role does Islam play in your everyday life when I'm dealing with Muslim populations? And for some people, they will say none. And again, like as my role as a psychiatrist, I'm not there to intervene on that. But if they do say some, then I ask them to tell me a bit about that and to share that part of their identity with me. And then the question I really like is, have you experienced any personal challenges or distress in relation to your religious identity or practices? And this is huge for me. This is gold. This is where a lot of young people then tell me, young and old, I particularly enjoy working with transitional age people, which is why I might sometimes say young, but across the age span, people will tell me that when questions of faith, for example, are raised within them, or when conflict with family comes in terms of how religious views or practices, that can create a lot of distress in their lives. And it's very much for them tied to how they're experiencing their mental health symptoms. And so you want to start broad. You don't want to assume that a problem they're having is grounded in their religious or spiritual struggles, but keeping it non-judgmental and open in this way allows the person to tell you what those interactions, what that overlap between their religious and spiritual identity and particular distress they may be feeling, or how they're using their religion and spirituality as a source of support. Suicide prevention is a really, it's a hopeful field, but it's a challenging field because it's very hard to move the needle when it comes to suicide prevention. But one of the tools that we do know is helpful are safety plans. So they had, again, done a study about this in JAMA Psychiatry. They found that when safety plans were implemented, they tended to reduce the risk of people attempting or engaging in suicidal behavior. So this one is taken, one of my colleagues, Dr. Zahir, designed this. and it lays out a nice one-pager that you can complete in collaboration with your client. So if you're a physician, clinician, psychologist, counselor, spiritual leaders can do this as well, where if a person is expressing safety concerns, then I sit down and I try to do this collaboratively with them. I ask them to tell me what are some warning signs that that are red flags for them, and reminding themselves the reasons of living, like we said, protective factors, coping strategies, people they can ask for help, and really having this plan laid out very clearly, so that when a moment comes where they may not have full faculty, when they may not have full access to being able to think clearly, this has already been pre-planned and somewhere safe and accessible for them. So if we come back to this case we were talking about, our 17-year-old young woman who's struggling with significant anxiety and now self-harming. And the first thing is, among this age group, thankfully, completed suicide, the rates are low and we haven't seen a particular rise. So that's good news. And I think helps to mitigate some of our anxiety as clinicians and people, first responders, people who are trying to address this issue. However, so that's the good news. Not so good news is self-harming and non-suicidal self-injury, so things like cutting on the wrists or other parts of your body, that's on the rise. And again, another whole lecture could be done on that, but for various reasons, that's on the rise. And what we know is that it's really important to differentiate those two. For most people, self-harming behavior does not immediately translate into suicidal behavior. They don't do it with the intent to end their life. That being said, it's still an indication that they're not well. Something is going on within them to create this level of distress, that this is being used as the only strategy that they have. So we still want to be very careful, and this is a very big safety concern. And we want to help people differentiate and to learn healthier ways of dealing with distress. But it's also important for us not to completely equate self-harm with suicide. Really, we come back to first principles, which is trying to understand the motivation. So for example, when I sat down with Sarah and discussed a little bit of the difficulties that she was having, really where these suicidal thoughts were stemming from is the idea that the pain that she was experiencing, the anxiety that she was feeling, the isolation that she was feeling, being bullied at work and losing many of her friends, and the confusion about how to navigate her identity, all of these were creating this distress where she felt that maybe death would be better than staying alive. So that's where the suicidal thoughts were coming from her. And so once we could understand that motivation really non-judgmentally, we could then work on alleviating some of that distress. How do we alleviate some of that anxiety so it's not as much of a contributing factor? How do we help you feel more connected? How do we get some help around the bullying? Once we decrease that motivation, then we're actually creating, we're planning for that person's safety, and engaging in the protective factors like I talked to you about. So for example, I'll show you a safety plan that I might fill with Sarah. So warning signs for her that she's not safe is that she's lying there in bed having repeated thoughts about dying. If she goes on Google and is researching like easy ways of ending my life, thoughts about self-harming, all of these should be red flags for her that this is, I'm not well, I need some help. reminding herself of reasons of living. So for her, this verse from the Quran, with every difficulty comes ease, was a big reminder for her that even in the past, when she has been through difficulty, she's noticed that some kind of relief eventually comes. So reminding herself there's hope there. And then family, best friends, her love of art, these are all reasons that she wanted to continue living. Coping strategies, like in the very immediate short term, where you just want to alleviate some distress, going for a walk, taking a warm shower, listening to calming music was all what was helpful for her. And then social situations where she can distract herself a bit, calling her best friend, attending an event in her social community, and then asking trusted people for help. So like you want to make sure in the safety plan you include specifics about the way to contact this individual or this organization. So for her, we included the Nasiha distress line, and in Toronto we have something called the Gerstein Crisis Center, where they have mobile teams that can come out to meet the person. Okay, I know we are at 1:30 and I do want to leave time for questions. I will fly through these because they've mostly been covered by Sheikh Hosam, but very, very quickly. Like Sheikh Hosam was mentioning, contagion is a well-documented phenomenon. We are aware that it exists and we have to be careful. So by this, we're referring to when there's a publicized suicide, rates tend to go up in that community. So it's necessary to have thoughtful and evidence-based ways of responding to suicide deaths. Principles can be that you do not make judgments about the deceased. You leave that judgment that is not within your scope, and do not share details about the death or suicide notes that have been shared, methods that the people died by suicide. We are told not to share these, and to also not sensationalize, romanticize, or rationalize the death. Like we said, suicide is very complicated. It's very hard for us to know what is going in the hearts and minds of people when they're considering this. So in the aftermath, where you have no concrete way of knowing, it's really important not to project your own ideas about why the person did what they did. What you can do, check in with each other, because that can, when these deaths happen, that can be really difficult on a communal level. Open up spaces, allow people to know that you're a safe person they can come and talk to, and share resources and encouragement for people to seek out, whether it is spiritual, religious, or professional help. And I'll just put up some of the distress lines as well here for anyone who's struggling, or if you want to pass these on to people who are struggling. And these are some of the references that I've used. Jazakallah khair for having me. Let's open it up to some questions.
Thank you, Dr. Furqan, and thank you, Sheikh Helal. That's a really important topic, and I'm really glad that there's research and education being done on it. We've had a couple of questions come in through the chat, and so I'll just take a look at those right now. Our first question is for Sheikh Helal, and it's about sort of the nature of accountability given in Islam to the actions of those who might not be in full control of their mental faculties, and what is said about that in Islamic sources.
Yeah, mashallah, that's a great question. First, Jazakumullah khair, Dr. Zainab, wonderful presentation, and the whole, mashallah, conference has been very beneficial, been in and out. But specifically about accountability, I think the individual who raised the question answered the question actually in the comments, citing the hadith in Sunnah Tirmidhi about the pen being lifted from 3 people: a sleeping person until that person wakes up, a child until that person becomes an adult, and someone whose mental capacity is limited in any way until they are able to recover their clarity. And also Ibn Hazm mentions, as for the person who's basically mentally unable to make those decisions, they have no like there are no requirements upon them, and Allah subhanahu wa ta'ala gives them the exemption until they're able to recover. So alhamdulillah, our deen is very beautiful, and there are lots of accommodations made, and we have to have like may Allah bless her, Dr. Zainab mentioned, we have to have a holistic approach towards the therapy and the discussion in research conducted on the topic.
Thank you very much. Our next question is for Dr. Furqan. You had mentioned about Islam being a protective factor, and you had some data indicating that that might be the case. I know it's difficult to draw conclusions from that, but I was wondering if you could comment on the question of maybe whether Islam is a protective factor against suicide, and if so, why that might be the case.
So that's a good question. It's quite complicated. Like you were saying, it's very hard to draw specific conclusions from general data. So I'll talk about what we know, and then I'll talk about how we interpret that. So like I said in the presentation, when they've collected worldwide data, the rates from Muslim majority countries do tend to show lower suicide rates. So in that way, we can think that living in a Muslim majority country may in some way be protective. Now, whether that's because of the specific religious beliefs, because of the deterrence and the perceptions of suicide, or the social connectivity that's protective. So when we say Islam, it's very broad, right? There's different aspects of it. But like I also said, that saying that Muslims, that suicide rates are lower in Muslim majority countries, that might be also influenced by how suicide is talked about and reported in those countries, right? So in a way, it can be considered protective, but it's hard to say on a general basis. Now, the data I was citing from the US, where Dr. Awad's team, they found that identifying as Muslim puts you at greater risk of having had a previous suicide attempt, indicates the opposite. Again, it's one study. We don't want to be over-conclusive about it, but that raises the question, is there something specific about being Muslim in North America that's exposing you to other stresses as well, that's countering the potential protective factor of religion? So for example, things like Islamophobia, racism, socioeconomic realities. Unfortunately, it's not an answer anyone loves, is that we can't say definitively whether it is or isn't a protective factor. But when they've looked in general, having religious beliefs and identifying as being religious does tend to mean, in general, having lower rates of suicide. That's a correlation that we have noted across data.
We have a question from the audience. How do we find the right balance between the awareness and destigmatizing suicide within the community without falling into contagion, romanticization, and rationalization?
Yeah, it's a very good question. I think Dr. Zainab alluded to it also, and feel free to add to this as well. But I find that khutbas are a very good place to begin the conversation in halaqat, in study circles, and framing the conversation about around the forgiveness and the mercy of Allah subhanahu wa ta'ala, and the flexibility of our sharia in accommodating individual circumstances, while also protecting some of the, being firm about some of the foundations of our deen in terms of what is halal and what is haram. So framing it in that way has been beneficial. And specifically, the conversation should begin with practical examples and end with practical examples. Like in our khutbas, we've done a few khutbas on basically increasing awareness, and the response has been phenomenal, very positive. And we usually begin by saying, look, suicide happens, and the thoughts can happen to the best of us. Beginning with Maryam alayhi salam, the best of women, she said, "Ya laytani mittu qabla hadha wa kuntu nasiyan mansiya." I wish I had died before this. And the Prophet Muhammad himself, Allah says about him in the Quran, فَلَعَلَّكَ بَاخِعٌ نَفْسَكَ عَلَى أَثَارِهِمْ إِن لَمْ يُؤْمِنُوا بِهَذَا الْحَدِيثِ أَسَفًا. Perhaps your concern over your community would lead you to actually losing your own life. So imagine Maryam, a woman, she's worried about, she's in pain, physical pain, the pain of labor. And she's also worried about the stigma that's going to happen and come from having a child and the questions that people are going to say. And the Prophet Muhammad, he's experiencing stress of the highest level, worried about the people that are around him. And the Quran says that if you continue in that and down that spiral, you might actually end up in a position where you lose your own life. Ayyub alayhi salam and Yaqub specifically, that Allah subhanahu wa ta'ala mentioned, that Allah gave him beautiful patience to be able to endure, but the stress was immense, and the anxiety of losing his son, at least that's the story that was told to him, it led him to actually becoming blind, as we know in the Quran. So that there are, subhanallah, physical manifestations of our pain, of our emotions. And we know that, and scholars in the past have spoken about that. But to know that it can happen to the best of us, that thoughts about, or to be in a position where you're actually, you may end up losing your life in the process, either being involved actively or it happening to you slowly because of the stress. It can happen to the best of us, the best of women, Maryam, and the best of men, Muhammad. So what does that mean about us, you and me? It's normal to have those thoughts. It's normal to have those thoughts in passing even, right? That's normal because we're human beings. But Islamically, we have to have constructive ways of dealing with that. That you belong, that this is your community, that we love you, that we care about you, that you are one of our community members, regardless of where you're at, regardless of your positionality. There are rules that Allah has set in place. Those rules, they're there to govern the big picture, to govern, and to make it clear what is acceptable and what is not. But the way that the rules manifest in each and every individual scenario, that's where rahmah and that's where compassion have to guide that conversation and guide the relationship that we have with these individuals. So coming from a place where there is no judgment, as Dr. Zainab mentioned, may Allah bless her, is important. But when we're having those conversations in a community level, we need to be clear about, again, from an Islamic point of view, right? I have the hat on, so I have a duty towards the tradition to make sure that the tradition is preserved. And so to be clear about that and to frame it that it can happen to the best of us, it's okay. Here are the coping strategies. Here are the tools that you can actually explore to cope, to heal in the process. That it's okay to seek help. The Prophet Muhammad says, "Tadawu, go and seek help." That it's okay to seek help, physical help and psychological help. That there are ways that you can access very good resources in the community. To destigmatize access to mental health resources and mental health professionals, that's the position I think that the masajid and the imams are in, because a lot of times people come to us and say, listen, I want to have a conversation with you. I don't want to go speak to this person or that person, because I feel like, again, Islam is something very important to me. And those are the people that are going to come to the masjid, and those are the people that are going to access the imam. So for us to be able to say, you know what, let's have a conversation spiritually, but the psychological implications, there are better resources available for you. And that's part of intellectual humility. And it happens on both sides. Like, for example, if someone comes to a mental health provider and that person is not en masse, that person is very religious and practicing, and you see that they can benefit from having a conversation with a sheikh and imam, that model actually works well, where there's referral and collaborative or cooperation between the two. And I've seen, honestly, that those are the best models. Like, we've tested a few models in the masjid where we just basically focused on, separation. Like, come to the imam only, and then we'll refer out-house. We'll basically outsource conversations with the mental health provider. And that didn't work well for us. And also outsourcing without having the support spiritually didn't work for us. What worked for us is when we had two people hired in-house in the masjid that were working together collaboratively to deal with cases from both an Islamic lens and a psychosocial lens as well. And those have been, from our point of view, very, very, phenomenal. So kind of to come back, what I would say is begin with practical examples of the Prophet Muhammad and, Maryam alayhi salam and others from the companions who experienced it, but frame the conversation in a way that destigmatizes access to mental health, conversation about it, and also work in the long term to create the resources in-house in masajid to provide the service holistically to the clients and to the community that needs it.
Dr. Furqan, if you wanted to add anything to the question.
That was very well detailed. I think that the last point for me that captures some of this in psychiatry, we sometimes talk about dialectics, is that sometimes two things which can appear opposing can coexist at the same time. And so I think within Islamic models and the way that religious scholars and practitioners have understood it is that deterrence and the strong stance around prohibition can coexist with stances of humility, with compassion, with non-judgment. Both of those things can exist at the same time. And when they work together, they can work together really well. I think sometimes we slip into these ways of thinking where it has to be one or the other, that if there is a very strict prohibition or if we're strong around that, then we're losing out on the compassion, the softness, the mercy, or if we go too much on the other side, that we're losing the sort of deterrence piece of it. What I'd encourage people to say is that we can hang on to both, we can balance both, and being able to balance both, that's where the Muslim community, that's where they're at right now. They want more of that, a better balance of that.
I think we have about 5 minutes left. I wanted to ask about the findings from Dr. Awad's study, because as she mentioned in the morning, I think they signal, a public health crisis, essentially. And so I just wanted to ask you to comment on maybe what those findings signal to you about both the needs of the Muslim community and maybe if they signal something about the care-seeking behavior among Muslims.
I can start there, and Sheikh Hosam, please feel free to comment as well. First of all, I think this study, it indicates what a need there is. The fact that that was the first study in North America that we really have character suicide attempts, that's quite telling because our community has been here for a while. So we do need more data. So I was very grateful to have that data seen. Again, I think it is a signal for us. So the authors during the study acknowledged themselves. It was self-report. So they were asking people to report themselves whether or not they had had a previous attempts. There can sometimes be issues with that because people might have different understandings of what is considered to be a suicide attempt or suicide behavior, and self-report, while it's very important, may not always be reliable. So there may be issues to that. However, given the significance of the findings that the Muslim population surveyed in this study showed almost double the risk than other religious groups of endorsing a previous suicide attempt, to me, yes, signals there is a really significant issue here that we need to address. And the causes for that really, to me, are multifactorial. So right now, what we're trying to do is do a qualitative study where we're sitting down with Muslim individuals. Our study is focused on younger Muslim individuals, and talk to them. Like my interviews with them have been 60 to 90 minutes, really understanding when you were driven to those suicidal thoughts and behaviors, what were the factors that were going into this? And we're hearing really interesting things. So issues around family conflict are a big one that can sometimes precipitate suicidal thoughts. Stigma around mental illness, not seeking out help until much later. And also lack of cultural safety. So for some of these people that I've interviewed, when they sought help in traditional mental health settings, so for example, in hospitals, psychiatric wards, their Muslim identity was not seen or acknowledged at all. One young woman was admitted, and her issues around hijab were introspective. So I think that it goes both ways. So Muslim populations might be hesitant to receive help, and that may be due to misconceptions about mental illness or stigma. But on the other side, our institutions and resources aren't always equipped, and they don't have the cultural humility to understand that people are coming from different backgrounds with different priorities. That was a long answer, but I hope it provides some context there.
I'm very satisfied with that answer. So for the brevity of time, we'll continue to the next question, inshallah.
Just briefly, I think this is for both of you. How could caregivers learn to support their loved ones if they're having suicidal thoughts?
SubhanAllah, it's a good question. I would say the best thing to do is to lend an ear without any judgment and to listen as much as possible, and to create active opportunities for individuals to belong. Like for example, even in our own experience in the masjid, I've had people that have come to me saying that they're struggling with suicide, struggling with addiction, struggling with anxiety. We've had conversations, we've had therapy sessions, healing sessions, and those have been good. They've been very good, positive. But for me, the most important, I guess, change that I've seen, and this was unexpected to me, is when we actually decided to go on a trip. We decided to go on a trip for 5, 6, 7 days, and we were just so busy, having a great time, enjoying just conversations about other things. And in that process of just belonging and feeling like, wow, I have friends, I have people that care about me, I have people that love me, I have people that I'm willing to, or that are willing to give me their time and energy, that has been way more impactful to individuals than anything else that I've seen. So I've had people say to me that, look, I've attended addiction counseling, and this may sound strange. I'm not saying it's not good to go to the resources available, but I've seen individuals come to me and say, like, look, I've tried everything to overcome addiction, but actually the 10 days that we went on this trip together, I realized that I don't need the substance. And I realized, because I was in that circle of people that really kept me motivated and kept me committed, and kept me kind of like just focused on other things, more productive things, I realized that I was able to overcome it, at least for that period of time. And that gives me now the motivation to access the other resources and to have that comparison point that I actually can do this. And the social support is again, sometimes undermined. You can go talk to a therapist as much as you want, but if you go home and you have a toxic family or a toxic circumstance or toxic situation, those hours can drain an individual. So it's important as Muslims to be as supportive as possible and as kind as possible and as compassionate as possible to everybody, especially those that we know are struggling with these situations, and to keep an extra eye, an extra attention. I think, of course, this can be one of the most rewarding things that we can do as Muslims. And maybe we can frame it to finish with the hadith of Rasulullah that he spoke to the companions and he said, for you to go and try to help somebody in need is better than spending 30 days of complete worship in isolation in the masjid of the Prophet. The masjid of the Prophet is a place where you get 1,000 times the reward of anything else that's done outside. So imagine 30 days of i'tikaf means 30,000 prayers, 30,000 fasts. That's a lot for you to go to try to help one person, just to try, not even to succeed, just to try to help, is more rewarding in the sight of Allah than all of that extra worship. So it's important to frame that from an Islamic point of view, as this is actually one of the most rewarding things that you can do, to be there for somebody, to listen, and to give them advice to the best of your capacity, or to facilitate them receiving advice. And one of the things that you can do, of course, as a friend, is also to destigmatize that it's okay. Let's go together. Let me help you. Sometimes people who are in that situation can't do these things, can't book an appointment themselves. Again, there's a lot of limitations in motivation in terms of being able to take that first step. So to be able to actually, okay, you know what, I'm going to go with you. Let's sit down together. Look, these are the lists of service providers, and here's what I think this person seems to be really quite nice. Here are some of the points that I've read about them online. This person would work very well with your personality. And you know what? Let me know your schedule. Let me book you in, and I'll drive you if you have to. So that support can go a long way in the process of healing.
I mean, yes. Thank you both so much for bringing this important topic and for educating us.